Geoff Sleight is on the way to see his consultant neurologist at the Leeds Teaching Hospital. He's recently been treated with MR Guided Focused Ultrasound, a non-invasive technique to treat essential tremor. But what was life like for Geoff beforehand? Ever since childhood, Geoff has suffered from essential tremor.
It has quite affected him, especially in the latter years. I'd say the last 5 or 10 years, it's really affected him badly.
It's not commonly known. People don't talk about it. They just live with the tremors, and we're only just touching the iceberg on reaching out to people to be able to give them that support.
Putting a ticket into a machine, putting a credit card in, putting tickets in railway stations, going in your wallet for a note, or putting a note back into a wallet.
Geoff developed a career managing nightclubs, bars and pool halls. When his hands shook, customers often thought he was drunk. Colleagues became very good at covering for Geoff. He even had to delegate tasks like serving drinks.
When you first serve a drink, you lift a glass to the nozzle, you'll always get a rattle on the glass on the seal.
Essential tremor can be really a disabling condition for a cohort of patients who have it. It can be lifelong and it can be very severe, usually both sides, and therefore it really impacts most activities of daily living. Most of these patients with really severe essential tremor, they're people who tend to respond only very poorly, if at all, to current pharmacological interventions. So as things stand at the moment, the only other option will be deep brain stimulation.
And what's the estimated temperature?
The procedure that Geoff underwent is MR Guided Focused Ultrasound, where around 1,000 ultrasound waves are focused from outside the head into a single point deep within the brain, without the need for invasive surgery or even to make an incision.
The treatment will be life-changing, no doubt about it. He'll be able to cook his own meals, make drinks, carry drinks in comfort without having to worry about cleaning them up off the floor. He'll be able to button up shirts, just move around and be so much more comfortable in himself. He'll be able to walk out the door and know that people won't be staring at him.
So that's your dominant hand. So let's put this one down. And can you do that?
Yeah, no.
Right up there. Okay, fantastic. Thank you very much.
Geoff's head must be clean-shaven in order that a water-filled membrane can be fitted to ensure a distortion-free transmission of the ultrasound waves.
We're looking at the tremor in his hand, and I was looking at it at different postures. He was holding his hand outstretched or by his nose. And here he's attempted to draw a spiral, an Archimedes spiral, and you can see it's very disrupted by the tremor.
During the procedure, Geoff is moved in and out of the MRI machine, so his tremor and other functions can be tested.
Oh. That's better.
Very good effort. Yeah, it is improving.
That's better.
Yeah, so it's more clearly a spiral, even though there's still a big tremor in there.
Yeah.
Just draw me the spiral. And just here, draw a spiral going round and round.
We have improved his intention tremor, which is the one where you hold your hand out there, and also substantially in the central component when we went quite low. So it should produce substantial improvement in drinking and eating and utilisation. This is the sort of procedure that we are looking forward to introducing to our NHS patients. Looking forward 5 years into the future, we anticipate that this procedure will be available in multiple parts of the country. Here we go.
A month on, and now Geoff is about to be assessed by Jeremy Cosgrove at the Leeds General Infirmary.
At the moment, management of essential tremor is, if required, is through medications, so pharmacological options. Only about 50% of people will ever respond, and that response can be variable, and of course the medications have side effects. There is a need for different treatment options in this condition, and that's why focused ultrasound is such a promising avenue.
It's virtually 100%. There's no movement there whatsoever. There is a little bit when it's under pressure.
Mm-hmm. But compared to before, much improved.
Much improved.
Pop your hands out in front. Good, and keep them there. So we've still got the tremor on the left, but it's almost completely disappeared on the right.
It's amazing.
Just bring your hands up to your nose like this for me. Good. Keep them there so you can see a real difference there. The left hand was always slightly worse than the right.
The left was the worst, yeah.
But you went for the right side because that's your dominant hand.
Yeah, yeah, rather than retrain the whole.
Yeah, just turn your hands up like this for me. Good, again, nice and still on that right side, and then this way. Good, and then out in front one more time. Highly focused ultrasound is approved by NICE for unilateral, so one-sided treatment of essential tremor, and that's been the case now for 18 months. There isn't at this current time a funding agreement in place, which means that the patients are essentially paying privately to have it done, and the only hospital in the UK with the equipment is down at St Mary's. I think it's very important that services across the NHS are provided equally, and that's something that we aim to do as a service. We provide equitable service. So although St Mary's has led the way for highly focused ultrasound and movement disorders, going forward I think we'd all hope that the service can be, that the equipment and the service can be spread out throughout the country so that everyone has equal access, and so that patients who might benefit don't have to travel all the way down to London as Geoff did.
Geoff, are you there?
Yes, I'm here.
Good man, excellent. Thank you so much for agreeing to do this for us today. I know it's not without stress, and I think it's wonderful that you are prepared to share your story for the benefit of others. Clearly, you decided to go down the route of being treated with MR Guided Focused Ultrasound, and we'll get to why and why that was and the effect it's had for you. But I just wanted to drill down a little bit in terms of the background. And we saw in the film that you've suffered from essential tremor since you were a child, which, as I understand it, is relatively rare. My understanding is that it is a kind of what they call a bimodal presentation, where you can either present as a child or present much later in life, sort of 40s, 50s, etc. So I just wondered if you'd share with us, how did it first present? How did you realize that you had essential tremor? And can you remember what you thought at the time about having this condition where you're shaking?
Yeah, I first started, to my memory, when I was about 18, 19, late teens, and I worked in various engineering companies at first, and I found I couldn't carry tea and write it was legible. Went to the doctor and he diagnosed it as familial tremors because my mother suffered with them. In later years, my sister, who was younger, did so also. And the doctor's remedy was have a drink. So being a teenager, oh yeah, sounds good to me. Yeah. And I went on to work in dance halls and nightclubs. where drink was around. And of course, we had to follow a doctor's instructions. And it was embarrassing. You hid away. You became a hermit to a certain extent.
Yeah.
People who knew you, family, etc. Yeah, it's Geoff. But strangers used to think I was drunk. I'd be Parkinson's, MS, or many other things. Some were cruel, some were kind.
Yeah, that was one of the questions I was going to ask you, Geoff, actually. Was, I mean, back then, society was a lot less tolerant of others and people with that were ostensibly different, if you like. And they were cruel, and arguably they still are today. And I wondered, have you noticed a change in society now? That are people becoming more tolerant and nicer, shall we say, to you?
Yeah, in the basis of shopkeepers, they are a little bit more patient.
Yeah.
You don't get the tutting behind you as you try to pay your card or take money out. And also, it's not unheard of since finding support groups, particularly in Leeds, where you realise you're not by yourself.
Yeah, I think that's a really important point you make, Geoff, that the work that NTF is doing in terms of raising awareness cannot be overemphasized in terms of its importance, because it's only through activities such as this and getting awareness into the media that people will become more tolerant and will recognize that this is just, it's pretty normal. There's 1 million people in the UK that have it. And I suspect the epidemiology is something similar in terms of prevalence in Suzanne's country, in Denmark. So I think it's great that we're doing all these kind of things to try and raise that awareness level and to teach society to be tolerant and not to be mean and horrible to people who have got essential tremor. I wonder if you could describe to us a little bit more about what you changed in terms of coping, disguising mechanisms, and what effect it had on your career, for example.
Well, change-wise, you always made sure the family made sure that the food was cut up.
Yeah.
You never had a full glass of anything. Drank bottles where possible. Tended to drink alone.
Yeah.
Tended first cup of coffee on the morning was over the kitchen sink.
Yeah.
Speciality of the house was pizza on our kitchen floor.
Yeah.
And you hide. You become very clever at wedging, as I call it. You wedge one arm, or you wedged one arm against the side of the plate, or button fastening. Yeah. And you tend to hide it that way.
Sure.
Instead of coming out.
Yeah. So I suspect you're not alone. I suspect many are nodding in understanding and appreciation and empathy, shall we say, recognizing everything that you're talking about. So what I was going to ask you is what made you decide to look for a treatment for it?
Nearly 2 years ago, there was something on television.
Right.
And I think it was the star of Coronation Street. And my ex-wife rang me and said, he's got it. Yeah. So why are you hiding it? And I made an inquiry with NTF.
Yeah.
And went to their meetings in Leeds. And very soon, wow, it's different. So I decided to find out how we could raise money to raise the awareness. And by doing so, I spoke to a very good colleague of mine who said, how much is the operation? And
right.
You've got it. He paid for me to go privately, which is a massive, massive thing, as I couldn't have afforded it. And it was the time factor. as opposed to DBS, and the risk factor as opposed to DBS. It just seemed right, the way to do it.
Yeah. So that's one of the, I think it's one of the questions I was going to ask you actually is, in the film, Dr. Cosgrove mentions deep brain stimulation, and it's clearly a very effective treatment for some patients. And for sure, there are also patients gaining benefit from a surgery that was kind of before deep brain stimulation, the radio frequency thalamotomy, which we're going to have a question afterwards about, I believe. So what made you decide for MR Guided Focused Ultrasound rather than using deep brain stimulation, for example?
Lack of risk.
Right.
1.5 days in the hospital,
Yep.
1 night. And the fact that it was virtually painless.
Right.
Although it wasn't uncomfortable,
Okay.
but you can imagine walking around with a Pelican Crossing sign on your head. It doesn't help, but it wasn't painful. It hurt, but anything hurts. And
that's what I was going to ask you actually, talking about the procedure itself. You know, what was it like? I mean, I work with it, but I've never had it done. Can you feel anything when the ultrasound is being performed? Does it hurt?
Feel very cold.
Right. Presumably from the water going around
the water
in the
going
membrane.
around in your head, on the head.
Yeah.
The worst thing I found was the injections into the skull,
Right.
to fixing the
frame.
The frame
Yeah.
worked too. But by the fact you're awake, you can convey any concerns that you have.
Yeah.
If I had to do it again,
Yeah.
if I was given the opportunity to have the other side done, yes, I would do it.
Yeah.
Let me put it that
So
way.
if we so that people can try and understand, if we compare it to for example to a dentist and the injections you would have to numb your gum before having dental work, and I find that very uncomfortable, arguably painful. Compared to that, how would you rate the injection of the anesthetic for the frame? Is it similar or
Similar? Yes. Yeah, because it's isolated.
Yeah.
Like a dental appointment is.
Yeah.
It doesn't affect anywhere else. And I talk to my daughter all the time. I was in having the procedure and the surgeons, etc.
Yeah, exactly.
And found it uncomfortable.
That must be quite reassuring to be able to still be able to communicate.
Yes, very reassuring.
Perfect.
It's not an invasive procedure.
No.
So I was told people will be with you all the time.
Excellent. And did you have any side effects?
Immediately afterwards, I kept walking into the dog.
Right.
The dog would look up and, what have we done that for?
Right.
Your balance is a bit screwy.
Right.
Tiredness, slurred speech.
Yeah.
I hope now the slurred speech is just about gone.
Well, I have to say I can't notice it, so I understand you perfectly.
My right hand tremors are virtually non-existent.
Yeah, we saw that in the film. It looked amazing.
Yeah, I can carry a cup. One thing was I went to Morrison's supermarket before the lockdown and got a cup of coffee myself.
Wow.
I didn't need to say, would you mind?
Yeah.
They went and did it for.
And how did that make you feel?
Great.
Yeah.
All of a sudden, it was new.
Yeah.
And I've had to change my hand, my style of writing,
right?
Because it was used to scribble, and now it's fairly legible.
Well, that's it. Your career as a doctor's gone then.
No, definitely.
So let's go back to the side effects for a second. How long would you say it took for them to go away?
For Bolland's, about a month.
Right.
For the slurred speech, it's ongoing.
Yeah.
I don't know whether it's, as I say, my right hand, it virtually rock steady.
Yeah.
And my left hand, I don't know whether it's psychological. That was the worst, which is why I went for the right hand to have one good one.
Yeah.
Without retraining writing, etc.
Yeah, exactly.
My left hand does seem worse sometimes.
Yeah.
But you still get bounce of tiredness.
Yeah.
But, you know, I'm 75, so I'm not going to...
Well, you're wearing it very well, and I think you've got more hair than I've got, so you're doing great.
Well, it's just growing.
So, Geoff, I've got 2 questions left for you, and then I'll leave you in peace. First question is, on a scale of 1 to 10, how happy are you?
Very.
That wasn't
10.
included in my scale of 1 to 10.
Very. 10.
Very good. And the final question for you before I move to Prof Nandi is, what would you say to someone else with essential tremor who was considering treatment with MR Guided Focused Ultrasound?
I would say consider it very seriously.
Yeah.
If you've got the facility for having it done, have it done, because it is a life-changing thing. It's not guaranteed. No, nothing in life comes with a guarantee. But from what I've seen, it's as near as damn it.
I think that's a really important point you make, that no therapy is 100%, and there are no guarantees with any kind of medicine or medical therapy. And you're right to point that out, that people shouldn't see this as a silver bullet or a holy grail. It isn't foolproof, and there will be some patients, hopefully a small number, a very low percentage, but there will be some that it doesn't help. And I think you're absolutely right to point that out. And I'm just very grateful and pleased that it did work for you, and that you're one of the majority, which is fantastic. And I want to thank you for sharing your story with us, and for spending this time having a chat with me about it. Hopefully it's been beneficial to the group. We will get to some questions, I suspect, for you later, once we've finished interviewing Prof Nandi. But unless there's something else you want to share right now, I will close there with you and move to Prof.
Like all the other people in the group, the strength is within the group.
Yeah.
And the treatment is there. And we all have families which are strong for us. We want to give it back. And NTF, with Moraine in particular, great.
Yeah, I completely, completely second those sentiments. I think you're absolutely right. It's a fantastic family that the NTF is. And the more work we can do together to help each other and to push forward with new therapies, not just focused ultrasound, but many other hopefully new therapies that can be beneficial, the better, and to spread that message, and to make therapies available to all, rather than just if you can afford to pay for it. It should be available on the NHS, amongst other therapies, and we'll get to that a bit later. So, Geoff, thank you ever so much. And with that,
My pleasure.
Yeah, great, thank you. I will mute you, or you can mute yourself, whichever, and I will talk to Prof Nandi. So, Prof, are you there?
Yes. Can Geoff still hear me?
Yeah, Geoff can still hear you. Yeah.
I just wanted to say I'm very impressed. Your hair, it's almost like I didn't shave it. Something in the Leeds water, Mr. Sleight. Send me some.
Yeah, I could do with some too, actually, Dip.
Different from when you last saw it, Prof.
You're looking great, Mr. Sleight. Lovely to see you.
Thank you. Thank you.
Right, so I'm going to mute everybody, and then I'm going to unmute you again, Prof. Let's go with that, and then I've lost you now. Prof, can you just unmute yourself? I've lost you temporarily on my list. So, Prof, if you unmute yourself, you're back. Yeah, there you are. Great. Just as a quick one for the group, I don't know what view you're looking at, but if you you want to be in speaker view, because if you go to speaker view, you will see whoever's talking, be it myself or Prof Nandi, large in the middle of your screen as opposed to a little thumbnail. And the way you find that is in the top right of your Zoom window. You will be able to toggle between gallery view and speaker view in theory. So if you do want to change your view, feel free to do so. So Prof, thank you very much for giving up your time on a Saturday. I know that you're extremely busy, particularly with the coronavirus and the impacts that it's having. And I know that you were operating very late last night as well. So you're looking very good on little sleep, so well done. And thank you for giving up your time today. So first question I have for you, actually. So we've heard from Geoff about his story, why he chose focused ultrasound and how it's affected him. What I wanted to ask you is, as a surgeon professor, why did you decide to become skilled at using this therapy to treat your patients?
So it was actually quite easy for me. So I've been doing deep brain stimulation for well nigh 20 years now.
Okay.
And, you know, as I think your film explained, Jeremy explained, it does involve quite a lot of intrusion. So we stick in these wires about 10, 15 centimeters deep into the brain on either side. Then they have all the excess wiring, the connectors, the pacemaker, and all that it entails. So when this technology came along, that you could actually go to the same part of the brain, and that's the critical bit, MRgFUS, deep brain stimulation, and the thing you mentioned before, the radio frequency ablation, the part of the brain we deal with is exactly the same. It's that tiny nucleus, which is about 3-4 millimeters across. But you can do this without having to open up anything. And that, as I think Geoff also alluded to, is the completely changes the safety profile and the risk profile. And, you know, for many patients, we turned on about something like 25 to 30% of patients turn us down for deep brain stimulation because they don't like the idea of such a intrusive operation with so much of implanted hardware which they carry for their lives. Which is a real shame because then they carry on with these symptoms, which is clearly affecting their lives. So when this opportunity came along, it was just a natural thing. So we still do DBS regularly, but whenever I get the chance, we do this.
Okay. So just for the group, if they aren't, as hopefully most of them are now aware, could you describe in very simple terms, you know, how does it create this? How does it reach the same area of the brain without opening the head, and how does it treat and stop the essential tremor?
I think the best analogy would be it's like children playing on the beach. A piece of paper and a convex lens or magnifying glass. Now, if you leave the paper just like that, nothing happens to it. You use the lens to converge a sufficient number of sun rays onto a point. You can burn that paper. So you can deliver enough energy to a tiny part of that paper and reach a certain temperature. It's exactly how this works. This is exactly, we use this machine's collimator. So it shoots through about 1,000 beams of ultrasound energy. Each beam in itself carries very little energy, doesn't disrupt the brain in any way. But where they meet, where they focus, it gets enough energy to raise the temperature of that little part of the brain, and raises it enough to cause a permanent hole, as it were, burn. And that's pretty much it. I think this is exactly how gamma knife radiotherapy works, a cyber knife, these clever ways of radiation, which I do. Yeah. Again, the same principle that each individual beam of radiation is small, and hence the brain is protected as it goes through the brain. But where they meet, you can deliver enough energy to kill a tumor. So I think that's probably the easiest analogy I can think of.
That's fantastic. I mean, that was so clear and simple to understand. Thank you. You did it far better than I would have done. So I'm very grateful for you.
Very modest.
One other question, you kind of alluded to it a little bit earlier when you said that roughly 25 to 30% of your patients refuse DBS. What I wanted to ask you, we know that there are approximately 8 times as many people that live with essential tremor as there are with Parkinson's. it's a much larger patient population that have essential tremor versus Parkinson's. And yet we also know that the ratio of those patients that are treated with DBS is actually the reverse. So in terms of which patients are treated with DBS, there are 8 times more with Parkinson's than there are with essential tremor, which is kind of relatively counterintuitive when you think about the patient populations. So I just wondered if you had any kind of insight, understanding that DBS is an effective therapy, which we know a lot of patients that you treat with DBS, it works for essential tremor. So why do you think it is that so few people compared to Parkinson's that have essential tremor are being treated with deep brain stimulation?
I think it's a function of how much it intrudes on a person's life and how much risk they would like to take. And interestingly, if you take that argument forward, a large proportion of the people who turn down DBS when offered on the NHS free are actually patients with essential tremor. And you can understand, and Mr. Sleight referred to this, and many patients, if not most, with tremor, with dystonia, they work out these little tricks to minimize the visibility or the effect, jamming your arm, not. So I suspect, quite tragically, people choose to live with the disability or the effect and compromise their lifestyles rather than take the risk. It's not just the risk of the operation itself, it's the long-term follow-up. It's a very intensive partnership we enter. We follow up all our DBS patients for life. They come every 6 months at least to have the programming redone. Sometimes they need battery changes, it's another operation. Sometimes the hardware fails, the wires can fracture, and sometimes it can be quite a serious consequence, and they have serious problems because of this.
Sure.
Now, in many ways, because of this MRgFUS, it takes away a large part of that concern. But one thing I must say is, we are talking of people, if you say people over the age of 75, I don't want to be, ageist, but generally, we would be very hesitant to offer DBS to someone in later years, because it is, the brain does lose reserve, the complications rise up. So that is what I think MRgFUS really has done, as opposed to sort of competing with DBS. It has opened a whole sort of panoply of choice for people who have suffered from tremor, whose tremor is getting worse, and who simply shrink into their lives rather than, because there is no option. Drugs don't work. There's only so much beer you can drink. So exactly. It just comes to the point where, and this because of MRgFUS, I think we have been treating patients well above Geoff's age, and the oldest, as you well know, was 93.
Essentially, so one of my questions for you, which you don't need to answer because you just did, was how important is it as a surgeon to have different treatment options available? And I think you hit the nail absolutely on the head, that people shouldn't see MRgFUS versus DBS. They should see it as an ally and a therapy to be used together. It opens up a new whole gamut of patient population, if you will, that you can treat.
If I just add something to it, James, is that, also a large proportion of DBS is actually for Parkinson's disease.
Yeah.
So there, DBS has certain advantages because it treats not just the tremor, but other things. But equally, somebody with unilateral, so one-sided Parkinson's symptoms, maybe early on in their disease, which is now medically failing, they can't control, people in their 40s, 50s, 60s, who stand to lose their job or having difficulty in their social life. It's an interesting combination. One could do a lesion on one side and buy them 5 to 10 years, and then they can go on and have DBS on the other side later on. So there are many options, as you say, because, and I think it's like any other thing, more choices you have, it's better for the patient. It gives them, things to choose from, and also it's better for us because we can optimize the management of an individual patient.
Yeah.
So.
Yeah, no, that's really interesting, because one of the questions we're going to have later is specifically on that point. So I won't dwell on that now. In the film, Prof Gedrock, he mentioned his vision for what it would look like in 5 years, and he suspected that MRgFUS would be available across the UK within the next 5 years. How realistic do you think that is?
I mean, it is, you know, the usual thing. There is only so much funding in the system. I think what would probably happen is, I'm hoping, is that just like DBS 25 years ago, it was quite a mountain to climb to get it available. And now, thankfully, it is. As long as we as clinicians are responsible, and then, you know, the charities involved, and then the patient organizations, if we work sensibly, I think what I certainly think should happen or can happen in the next 5 years is the patients who need it the most should be able to avail of it. And so again, this is a problem with any new technology. I think sometimes there is overuse. This is was very much seen in the last couple of decades with spinal instrumentation.
Yep.
You know, surgeons trained on it, and they started doing it willy-nilly. You know, often many patients have had surgeries which probably could argue they didn't need. So I think a degree of responsibility it's really upon us as clinicians to be careful. If you apply those kind of guidelines, and hence MDTs, you know, doing it in multidisciplinary teams, and the most important people in these are the neurologists who treat these all the time.
Yeah.
Well, I'm essentially a man with a hammer. You know, so,
I think you're underselling yourself somewhat there, Prof.
But when you do that and then you apply it, the number of patients who will need this treatment is actually going to be relatively small.
Yeah.
And I'm hoping there'll be enough capacity in the NHS across the country to be able to cater to that.
Great. So that brings me to my final question for you, actually, which is clearly the NHS has had a huge amount on its plate over the last few months with COVID-19 and coronavirus. And we cannot commend you and your colleagues enough for everything you've done to keep us safe, keep the NHS afloat, and to try and contain the disease. And those who've been suffering from COVID, and one of whom was you, I understand.
Yes, I was going to say, this is one thing I know from the inside.
Exactly.
It was not nice.
We're very, very glad that you recovered. My understanding was you got it pretty bad, so welcome back, and I'm very glad you're still with us. And what I was going to say was that even the NHS England process itself has not escaped the clutches of coronavirus. And what that's meant is that, and this is part of the update I was going to provide later actually to the group, that there was supposed to be a prioritization meeting in May this month around the NHS commissioning policy that they've developed for MRgFUS. That has now been delayed, and it's anticipated that it should take place at the end of July. With a fair wind blowing, and if we continue to defeat coronavirus. So what I was going to ask you was, now that we are seemingly on the downslope of the curve, if anyone from that CPAG committee were listening to this, what would you say to them about making MRgFUS available on the NHS, and almost as importantly, when should they do it?
It's not easy for them. I can understand that. There are many new treatments, and some of them are very investment heavy. But I would again go back to when we were arguing the same case for DBS about a couple of decades ago.
Yeah.
Is that if you treat a patient with intractable tremor, which is medically refractory, which is interfering with their life, ultimately society actually makes a saving, because, you know, they become more independent. Many of them hold jobs, and they probably get less accidents, which will land them in hospital. They have to go to the doctors or neurologists less often. So if you take a long-term view, applied judiciously, I think this is not such a big investment. But I agree, the capital cost is substantial. But if you look at it over a 5-year return, I think the NHS will save money. So I would say they should think in that fashion. I know it's easier said than done, but yeah. The evidence is, you know, absolutely incontrovertible. I mean, there is no question. The evidence is not just since MRgFUS came up, which is only a few years. The evidence that thalamotomy works is over 70 years old, well before CT and MRI came. So there is absolutely enough scientific literature there, enough patients have gone through this treatment. And this is simply a safer, easier and cheaper way. DBS implants cost the earth.
Right.
A single DBS procedure for 2 sides in any given patient, just the hardware alone is anything between 30,000 to 35,000 pounds.
Wow.
MRgFUS has no implants, has no consumables. So, in a way, so if you just look at the money flow and the workflow and the personnel involved, it's really actually a cost saving thing. And also, as I say, in the quality of life indices, it is, to paraphrase the great man, never has so much been owed to so little. But you have to take a long-term view, because I agree, setting up is hard.
Prof, I think that's a fantastic way to close, and thank you so much. It's been incredibly insightful to hear your opinions and your expertise, and thank you for sharing that with us. If you do have a few more minutes to stick around to answer some questions, I know there are a few, if that's okay. And I'd like to kick it off with a couple of questions that were sent in advance of the call today. So the first one is from the Scottish Tremor Society. So Mary, you can prick your ears up at this point. And the question specifically is it possible, and this is for you, Prof, is it possible for someone who has had DBS but subsequently had it all removed, is it possible for that patient to subsequently now go for focused ultrasound?
Absolutely. If the implants are out, then absolutely.
Okay, great. So hopefully that answers your question, Mary. And then there's a question from another chap on the call today. And he asked, in February, he had the left side of his brain treated with radiofrequency ablation. So the older methodology to achieve a thalamotomy, shall we say. And by all accounts, it's gone very well. He's happy. It's great. Very good. Very good. Thank you, Colin. So his surgeon has offered him the possibility of having his other side done next year. But his surgeon did stress that there's a greater risk involved, and that the benefits in his non-dominant left side may be not as good. So Colin, I'll give his username, he's interested, but he's unsure. And his specific question is, on the basis he's already had a thalamotomy on the right side, would focused ultrasound be a safe alternative for his left side, assuming the NHS fund it?
No, I mean, I'm glad it worked on one side. That's great. His surgeon is absolutely right. And we know this from decades of experience with thalamotomies on both sides. There is a multiplicative risk, and which is why I think whoever's looking after him is the absolute right thing. You stage it. You wait a minimum of 6 to 9 months from one side to the other. The greatest risk is in the speech becoming unclear, what we call dysarthric, and in balance, in walking. Some of it is predicated on how he is now, whether he has any of these issues already. If age has a factor in this, it's slightly greater if you're beyond the age of 70, 75. But overall, there's equally a wealth of published cases of bilateral, both-sided thalamotomies who have done quite well. So I think there is no question that it can be done. There's absolutely no question that there is a slightly higher risk profile. I would say, though, one big advantage of MRgFUS doing it on both sides is because of the way we do this, there is no probe going through the brain. So with the probe, with the radiofrequency thing, you are limited to the tract or the trajectory of that probe once it's in, or you'll have to really shift around in the brain, which is dangerous.
Yep.
With MRgFUS, you can aim whichever way, we can shape the lesion, we can move around in the patient's brain by a millimeter or so very safely, but there's no tract. So I would say bilateral definitely has a bigger risk, but if one were to choose to have it bilaterally, I would think MRgFUS actually has a much better range of options than doing it physically with the probe.
Okay, so the one thing I need to point out at that point is that for the moment, at least, MRgFUS, its licensed indication is for unilateral thalamotomy. So it would be an off-label, I think, use to do it, and we certainly are not licensed to do that.
But you're aware, the Imperial, we are doing a trial, part of a multi-centric international trial of doing both sides. And we did do our first patient.
That's true. So
who's
yeah, I
done
think you're
very
right.
well.
Within a trial protocol,
Within a
it's
trial,
okay.
yeah.
But I think it's important to point that out, that it's not a procedure that anybody could have bilaterally. It's a unilateral indication. And you're right, within a trial protocol or research protocol, then it's a different story. But it's important that we do make that clear. So thank you for that. So with that, I'm going. They're the two questions I had sent in already to me. I'm going to now call on various people who have registered an interest in asking a question. And if you still wish to ask your question, then please do so. If you feel that your question has either already been answered or it has become redundant for some other reason, then please just say, it's okay, I'm happy, and we can move on. So the first one is Brenda Carley. Brenda, are you online? If you are, unmute yourself. I don't know if I go to manage participant, maybe I can see who is online. Find a participant, that's the easiest way to do it. Right, Brenda. And I don't think Brenda is with us. So the next one in the list is Suzanne Thorndal. Are you with us? If you are, please unmute. Suzanne. This is going well. I think we're 2 out of 2 not here. The next one on the list was, oh, hello.
Yeah, I'm here.
Hi, Suzanne. Hi, welcome.
Hello.
So please tell us your question.
Hello, I'm from Denmark, and I'm chairman for our union here, and I'm fighting for. Can you hear me?
Yes, we can. Absolutely. Yes.
And I will do my best to speak English and make myself clear.
I guarantee it's better than my Danish, so it's okay.
Okay. I think I have got a lot of answers to a lot of questions I had, and I think there's a lot of good material on the internet at this treatment, so I think you do a very good job here to come out with the information. So it's kind of funny question. I'm that kind of person, I think, but what I would like to say is that it is. We fight for this in our country as well as you all do, and there's a lot of work to be done to reach out to the state and all the people to understand our illness, sickness, and to get some help. And this treatment is a very nice alternative to DBS, and we're of course very happy that this has come so we can be treated. I have personally a lot of questions of the ages, but we can take that another time.
Sure.
I'm nearly ready for the treatment, I think, but I would like actually to hear if we can help each other, if there is some countries who help each other to reach the popularization and the state to understand this, because we can all see that the treatment is good, but it is very hard to make everyone else to understand that this is a good treatment. And I think it's like, I don't know how you are telling it in English, but I don't like to make the plate myself again. I like to not to reinvent this. Yeah. So I don't know. Is there any?
So I think I probably, if I understand the question, I'll try and rephrase it, and you can tell me if I've got it right or not.
Yeah.
It's about collaboration and
Yeah.
helping each other in the different countries to move forward and make progress with the
Yes.
availability of new therapies. Maybe not just focused ultrasound, but any new therapy in this environment. And I think what I would say to you is that I think there's certainly a capability or a possibility to collaborate. One thing that may well be of significant advantage to you in Denmark, my understanding is that the Nordic region as a whole, and particularly Denmark, has quite a keen interest and focus from a healthcare provision perspective as to what UK does and the NHS. And where we are at with the NHS now is they have developed a commissioning policy. So they are looking to make this available on the NHS to treat patients for free. And they're looking at treating up to 150 patients per year. And they're at the end game, if you like. They're reaching towards the end of making it available. And this is this meeting I was talking about with the prioritization. Once they have that meeting, and they hope to have it, and it's their words, not mine, they hope to have it at the end of July, then in theory, it could be implemented within this year. Where I think, to go back to the collaboration thing, as soon as that happens, I think we should share that with you, Suzanne, and your group in Denmark, that you can then take that as your ammunition, if you like, to the Danish Health Board and say, look, if it's good enough for the UK, it's good enough for the NHS, why is it not good enough for the Danish Health Board?
Yeah.
And I think that's where we can help you, and you can help us also in terms of applying that pressure on the politicians and the decision makers. Because patients around the world all agree that they want this available, and other therapies, obviously. What's important is that the decision makers who have the money and they have to decide, make the very difficult decisions as to where they spend that money. It's important for them to understand how important this area is. So I'm thrilled that you're on the call, and thrilled that you want to collaborate and work together, and hopefully we can really benefit each other's countries.
Yeah. Okay. Thank you.
Cool. The next question I had was from a lady called Sue Whitehouse. So, Sue, are you there?
Yes, I'm okay.
Hi,
my question's been answered. Thank you.
Okay, perfect. Thank you for that.
Thank you.
You're very welcome. I'm glad that we answered it already. It means we're doing something right, at least. We're talking about the right subject. David Sproat, and apologies if I've mispronounced your surname. David, are you there?
Yes, I'm here. I found this webinar very informative, and my questions have been answered, and I look forward to taking part in future ones.
Wonderful. Thank you very much. That's great to hear from you. Geoff, Geoff Sleight, you're down to ask a question. Is there a question you wanted to ask, Geoff?
Oh, am I? I wasn't aware of it. I must have slept.
Oh, very good. Sounds like we can move on then. Thank you. Ralph Cousins. Ralph, are you there?
Yes, I'm here.
Hello, Ralph.
You've talked. Hello. You talked about the hand tremor. I've got tremor. It's about 75% of Geoff's, which has come on in recent years, and I too have difficulty writing. But my tremor is a head tremor, which is, I'm 83 now, and it started when I was 13.
Wow.
Quite frankly, I have sort of adjusted, learned to cope. I'm okay in public. I'm quite happy speaking in public. But I was just wondering, is this treatment, is it only good for head tremors? And in fact, could I have the treatment in view of the fact that the head is shaking? Would I have to be sedated?
That's a great question. Prof Nandi, I'd like to pass that one to you, if I may, to answer, if you're still with us. Prof, are you there?
Yeah, sorry, I can hear you, yes.
Yeah, great. Could you, do you need me to repeat the question, or did you?
No, I heard Mr. Cousins, absolutely.
Great.
So, unfortunately, head tremor is a tricky area. Does your voice, has that changed as well? Does it shake, can I ask?
Yes, I mean, people sometimes have difficulty in understanding me as if I do stutter a bit. Could I wait there, just ask something? I was put on propranolol some years ago, which did reduce the tremor, but then I became unsteady on my feet, and I had a slight electrical irregularity in the heart, and the consultant told me to stop taking propranolol because I believe there is evidence now that it can cause unsteadiness, and I believe Camilla Parker Bowles' brother was on propranolol. He fell over, hit his head, and he died. So, and also in the early days, I had hypnosis, which probably taught me relaxing techniques, but whether in fact it did any good, I'm not sure. Sorry, it's quite a lot.
Prof?
No, I understand. I mean, briefly, I would say this is probably not the right way forward for you, Mr. Cousins, unfortunately. But it's ongoing work. If this were to become very progressive, I mean, I got the impression you said you had adjusted to it. You can go out, you can speak in public. If that's where you are at, I would say I wouldn't recommend MRgFUS. If this were to worsen progressively, one could revisit this.
Thanks, Prof. I think it's a great answer. I think it's the important takeaway message of that is that it's exactly what you were saying earlier about not over-indicating a new therapy and being careful who we offer it to and who gets treated to ensure that it remains available, and that more research needs to be done, clearly, in terms of potentially widening and the breadth of the indications that it can treat. And it's really refreshing to hear an eminent professor such as yourself not trying to over-egg the pudding and saying, this thing can treat everybody. And that's really refreshing because, trust me, I hear you when you were speaking about the spinal surgery world, which I used to work in many years ago, and you're exactly right. Things have, new therapies have a tendency potentially to be over-indicated, and it has the unfortunate side effect, if you like, that over-indicating a therapy actually has the potential to stop it dead in its tracks and prevent it being available then for patients who can benefit. So hats off to you for your ethical approach, so thank you. The next question is Richard Staskowitz, and again, my apologies if I have mispronounced your surname. Richard, are you there? I'll give him a second to unmute. If I shall see if I can find him. Yeah, you are there. I shall unmute you, Richard.
Can you hear me?
I can. I've just unmuted you, and yes, we can hear you. And apologies if I got your name wrong.
Okay. It's just about cost, really. If you do go privately, how much does it cost?
Okay, so Prof, again, one for you.
So the trust has set a tariff. It's £22,000, and it includes the scans. There are several scans involved before. It includes obviously the treatment itself, and also we tend to keep you for a night in our private wards. So that package, they've pegged it at £22,000. It's quite a steep price, but that's where you are.
Yeah. Okay.
Does that answer your question?
Can I ask a follow-up?
Yes, please do.
If you talked about it being applicable to one side of the body, I get a tremor in the face as well. Does it? Will it treat your face and one side of the body?
So it will treat one side, especially the arm or the hand, very reliably. The face is something like Mr. Cousins' situation. It's difficult to predict with all of these lesions. It might make no difference. It might improve it a bit. But in a subsequent time, if you were to have the other side treated as well, then there can be probably a better effect on the face when both sides are treated. But
yeah,
it's I would say there is very soft data, and I wouldn't tell you that your face would be better.
okay.
Again,
Thanks
thank you
very
for your
much.
honesty, Prof. It's again refreshing. Mary Ramsey, was your question already answered or not?
It was, but I since have another question that
Okay.
perhaps the Prof could answer. I have a lady that has had essential tremors since childhood. She has been to see about getting DBS and been told that she's not a suitable candidate. Would it be worth her looking to see somebody to see if she's suitable for the focused ultrasound?
So that's a very important point. I suspect the reason they said the DBS is maybe she has other medical issues. And if that's the case, then focused ultrasound would be a fantastic alternative. If you want to take this forward, I think easiest maybe to let James have the details, speak to the lady, and if she's happy, James will let me know and we can contact her.
Fine.
Perfect. Thank you, Prof. Thank you, Mary. And the next one on the list is Beverly Thomas.
Oh, hi. Thank you very much, all of you, for the information that you've been giving today. I was going to ask about head tremor. That's been answered, but can I just ask whether there are any developments in terms of head tremor treatment if this isn't suitable? Maybe you can't answer that today, but maybe that's something that could be addressed.
Prof, is there anything else out there that's not focused ultrasound?
It's the problem with all movement disorders which affect the midline, as it were. They're always more challenging for medicines, for surgical therapies, including DBS. It's not that these things don't help, but they help much less reliably. So if someone were to have significant hand tremor, and along with that the head, I would say there's every reason to go ahead. But if the head were to be the main problem, I would hold back.
Does that answer your question, Beverly?
Yes, thank you very much. Thank you.
No, you're welcome. Next on the list is Richard Law.
Hello there.
Hi, Richard.
I didn't realise I was asking the question, but I just wanted to. I just wanted to really know. You have answered it up to a point.
Great.
How much did you suffer after having the treatment?
So, Geoff, I think that's one for you.
Hi. Immediately, not too much. I went by taxi after the procedure. Went by taxi, spent overnight in the hospital. I slept quite well, and then travelled by train the next day up to Leeds. It was more strange than suffer. You had to get used to make adjustments with your balance. No headaches, stuttering, and the balance were the main things that were wrong.
How was your speech before you had it done?
Okay.
So having it done made your speech go downwards?
It made it slur, but like I check with my kids and what have you, how am I talking today? And it is getting better week by week, and it's virtually back to normal now.
So when you came home, how was you able to cope indoors?
Fine. I was lucky I stayed with my daughter for a couple of weeks, and I had family support around. I was okay. Odd little bit of imbalance, but that's all.
Because the problem I've got, I'm on my own.
Same here.
Yeah, but I've got no family.
I don't know. I can't honestly say. It depends on you as an individual as to how you would feel.
And I think that's a really good important point, Geoff, as well, that everybody will have potentially a different reaction, different outcome, different clinical benefits, or not, as the case may be. I think it's wonderful to hear your story, Geoff, but I think we have to be cognizant that this is one patient and one story out of thousands of patients that have been treated. And we shouldn't assume that what Geoff has experienced is going to be the same for everybody.
No, I agree. It's the individual, how it affects you.
I understand that.
Good man, Richard. Good man.
Yeah,
Richard, I'm going to move on if that's all right, because there are other people wanting to.
That's all right. That's fine. That's fine.
But feel free to connect again with Geoff afterwards or in future sessions, or myself. Absolutely. The next one on the list is Jan or Jan Kermain. Again, my apologies for any mispronunciation. Is it Jan or Jan? I don't know. Are you there?
Somebody's joined us at the bottom.
Is that Jan? No. Okay, we're going to move on then. Kim Oliver. Are you there, Kim? So let's try and find her. Kim. No, I don't think Kim is there. Beverly Thomas, we've asked already. Ken Lowe. Is Ken there?
Yes. Hi.
Ken, it's your turn. Your numbers come up.
Oh, thank you. Can you hear me?
Yes, we can. What would you like to ask?
I'd like to ask Professor Nandi, how long ago was the first patient treated? And is their tremor still, is he still or she still free from tremor? Or does he or she have any side effects?
That's a great question. Really great question. So Prof, can you explain a little bit about how long this can last and how long ago was your first patient?
I agree. This is obviously a very, very important question. Now, I'll do it in two halves. So just speaking for us with MRgFUS, we did the first one, I think, July 2016, if I remember correctly. And the effects are exactly the same. So this is one thing about, and we actually expected this. If you make a big enough burn, a big enough lesion or a hole, then the effect with the tremor actually lasts decades. And we know this because the same applies to the radiofrequency ablations, which have been done for over 70 years. So making a hole in the thalamus in that particular area, the tremor tends not to come back. But what is important, and this is why, Mr. Sleight, you have to push the boundaries. And that's why it's so important that we can do this with the patient awake and we can assess. So I work with Dr. Peter Bain, the neurologist, and we assess regularly during the treatment. And you have to push it to the point where they are having a slight problem with their speech or slight difficulty with the hand. Because if you back out too early, when the tremor stops, then you make too small a lesion and it tends to come back. So it is a very fine balance between risking a side effect versus getting a long-term resolution. But if you get it right, it doesn't seem to come back with time.
Good. Thank you very much for that, Professor. Just to say that you helped to treat me in June 2017 with FUS.
Yeah, you looked familiar.
And my tremor is still almost non-existent. Thank you.
Your hair actually misled me. I thought maybe I'm getting confused. You can't have so much hair. I've gone through you.
That's fantastic.
To hear that, Mr. Lowe.
So we have at least 2 patients on the call that have had focused ultrasound. That's very exciting. The next one I have on the list is Michael Goddard. Is Michael still with us? If he joined at all? Michael, are you there? Doesn't look like it. Okay, and then the final one on my list, and then I'll ask if there's any that have materialized during the session. And the final one I have is Anthony Willis. Anthony, are you still with us? I sound like some terrible radio chat show host. Anthony? No? Okay, so in which case, is there anybody else that would like to ask a question that that hasn't already? Speak now or forever hold your peace.
I would. Yes.
Hello. Hi, Lindsay.
Hi. I just really wanted, I think he sort of answered it, the professor, but I just wanted to ask, I have tremors in my hand, but I also have a voice tremor. And I just wanted to check whether the ultrasound would help both or not.
So, Prof, over to you.
It'll help the hand much more certainly. The voice is always something difficult to tell with the voice, and it shouldn't make it any worse, but you know, there is a chance it might make it better. If we ever get around to doing both sides eventually, then I would say there is a greater chance of making it work.
Yeah. Thank you.
No problem. Thanks, Prof. Mary, was that you with another question?
I've had essential tremor since I was born, which is basically 63 years ago. I do find that when I get tired, my speech tends to slur. Now, the DBS doesn't help the speech. But if I had somebody that had the same problem as I had, do they think that the focused ultrasound would help the speech?
Yeah, I'm sorry to hear that. The problem is, you know, like you, if somebody has a speech problem already, did I understand you correctly? Have you had DBS for this already, or you have not?
Yes, 17 years ago.
All right, okay. So the problem is, if you already have a speech impairment, the risk of making it worse with the MRgFUS is actually higher. So I would be very careful. So I would say it's not,
As I say, it seems to be if I get tired.
Yes, which is true for everyone who, you're absolutely correct. Even the tremor, sometimes, I don't know if you noticed this, when you're fatigued or stressed is worse.
Yeah.
But so would apply for the speech, yes.
That's fine. Thank you very much.
Thanks, Prof.
Would I come in with a question? Is that okay?
Yeah, hi, John. Yeah, please do.
Hi. Nice to meet you, James. Well, what I wanted to ask was, I mean, as James will be aware, I've been in a supporting role with Mary Ramsey petitioning the Scottish Government to make this treatment available to people with essential tremor and also other conditions in Scotland.
Yeah.
What I want to ask was, would Geoff and Professor Nandi be willing to provide oral evidence to the Scottish Parliamentary Petitions Committee, who are currently in the process of considering the Scottish Cabinet Secretary's response to Mary's parliamentary petition to introduce this treatment option in NHS Scotland. And one of the things that would be useful in terms of furthering the petition, which thankfully was lodged before the COVID crisis, which keeps it on the health radar in Scotland, is that a lot of what the Scottish Minister came back with was economic considerations. So I just wondered what you guys thought, and I'd carefully noted the figures that you sort of made around potential savings being made by year 5. What are you guys thinking about that?
So to repeat the question for Prof and Geoff, if I understand it well, John, is you're asking whether they would be prepared to provide oral evidence to the Scottish Parliament by way of assisting with the petition, and to share the evidence such as the data and patient outcomes, etc.
Yeah.
Great. So
yes is the answer.
Was that yes for you, Prof?
Yeah.
Good man.
No
and Geoff? You still there, Geoff?
Yes, no problem at all.
Good man. Excellent. So John, I think we can very happily rely on their support. So thank you. And of course, I will continue to help where I can as well.
Yeah, just
we all have to work together.
As I've seen, James has been a continual support. It's nice to meet him in the electronic flesh, if that makes sense. But yes, Insightec have played a huge supporting role, as the Essential Tremor Foundation obviously goes without saying. But Mary's work is quite amazing. Our project in Highland is to increase the number of disabled people taking part in decision making regionally and nationally, and she's an example of this all.
Absolutely. Thank you for those kind words. So Bob and Jan, is that you there? I see. We missed you when I asked earlier on. I apologise.
That's all right. We weren't sure whether you could hear us or not.
We can now, so please do ask a question.
Thank you for a very interesting time. We've enjoyed it very much.
Oh, great. You're welcome.
Yeah.
Thank you.
Thank you.
Oh, you have a question, or is it?
No.
Oh, wonderful. Well, that's really kind of you to persevere in order to say that. Thank you. It was really kind. Anybody else around the group? We're close to 1:30, so I might suggest that we close at 1:30. Yes, is that Ian?
Yes, I agree. Very, very interesting talk by everybody, and thanks, Prof, for giving information that I didn't know, and lots of information. My question is, how many institutions around the UK offer this ultrasound procedure?
So I could probably answer that one, which is, for the moment, it is only available in St Mary's in London. With the NHS looking to make it available routinely to a number of patients, there is the expectation that there might be more centres looking to acquire the technology in order to deliver that service. As it stands today, as I say, there's only the one system. We know of approximately 3 or 4 hospitals that are actively working on projects to try and make it available in their hospitals. And Leeds, where Geoff is from, are very keen to try and get the technology. What I would say is that if we take it offline, if you want to send me an email, I know that any hospital that is trying to find a project or develop a project to get the system, they would be incredibly grateful for any support that any of you can give them in terms of generating local noise, helping with fundraising, etc. So please do send me an email if you'd like to get involved with trying to get your local centre or your nearest centre up and running, shall we say, and I can certainly point you in the right direction and give you the armamentarium that you would need in order to be able to offer that and provide that help.
Okay, thank you very much.
No, you're welcome. So yeah, do send me an email. In fact, what I'll do is I'll put my email into the group chat now, and then everybody will have it, and I can hope I've spelt it right. Yes. And then, as I say, I will answer as many and as I can. With that, it's now reached 1:31. We're running half an hour over. I'm very conscious that Prof Nandi in particular has given up his Saturday lunchtime for this, and I'm incredibly grateful, as I'm sure the rest of the group are. I apologise if I've not got round to answering a question for you. If you do still have questions, again, please use that email address I've just put onto the group chat. And with that, I would like to hand back to Jackie with my thanks again to Geoff, to Prof Nandi, and to all of you for giving up your Saturday to listen to us. and hopefully it's been helpful. And with that, Jackie, I will hand back to you with my thanks.
Thank you.
Jackie, it's your turn. Are you there?
Right. Can you hear everybody?
Yeah.
I would just like, yes, I would just like to send a huge thanks to James for coming along today, Professor Nandi, and to Geoff Sleight as well. Thank you for this very informative and educational talk.
Second.
And also to everybody who's been asking questions as well. I think for some of us, we don't always think of a question until after the event. So if anybody does have any questions, you can either email us at events@tremor.org.uk if you haven't got James's email at this point. And if it's for James or Prof or Geoff, we will forward it on to those people. Well, I think if you would feel that you would like a follow-up of today, because I feel there's a lot more questions or a lot more information, and how lovely to be international today. I know people have been, you know, it's their lunchtime, but I'd just like to thank the people joining us from other countries as well, and look forward to working alongside, you know, coordinating with other countries. So maybe, James, at some point, the Awareness Day in Leeds was due to be all day, so a lot of you would have been able to have, you know, more time to ask your questions. So maybe, James, a webinar would be on the cards somewhere.
I'd be delighted to. Maybe not next week, but no, I'd be very happy to keep coming back. And as we've said all along, it's very much a combined effort. We all need to work together, and it was wonderful to have Suzanne with us from Denmark. The more people that are talking about essential tremor and all of the potential treatment options, including guided focused ultrasound, the better. And it can only be a benefit to all of you who have to live with the essential tremor. And I'm very conscious and very grateful that I don't have to live with it. So I can't even begin to imagine what you guys live through every day. And anything I can do to help make that better, then I'm happy.